It is Tuesday. It is March. Welcome to March. Today we have a Zoom and Learn presented by us here at Celebration Magazine Live. I am Zoe Frost, your hostess with the mostest. And today we have Dr. Amira Awad with Dental Health Specialist. Now, the really cool thing about what she does is she actually specializes in dental care for older adults. And she's going to be talking about all kinds of cool stuff today. I got a sneak peek of some of the cool technology they're using. So I am going to turn everything over to her. Dr. Awad, thank you so much for joining us today.
Thank you. So I appreciate it. Thank you for having me. I apologize. My baby is a little restless right now, and I asked her big brother if he could watch her just for a moment while I joined in with you guys. So I apologize for that little outburst earlier.
Well, hey, and look, if you need to put her on your lap while you present, we're okay with that too. We love kids. We've got dogs that join us for our Zoom, so you do what you need to do, okay?
Thank you,
Of course.
All right, so if I can go ahead, I'll go ahead and share my screen. Is that okay, Zoe?
Most certainly. The floor is yours.
So I wanted to first start out and introduce myself. My name is Dr. Awad. I am the proud owner of Dental Health Specialists. We just opened not too long ago in Plano. So who am I? I am a proud mother of 3 young ones, a 12-year-old, a 10-year-old, and now a 10-month-old baby. My husband, thank goodness, is not dental related. He's a cybersecurity engineer, so I can go home and I don't have to talk about dentistry. But he does tell me all the things about cybersecurity and hackers and all the things he's seeing nowadays. So that's really interesting. I did my undergraduate education at, it used to be Baylor College of Dentistry, but A&M bought Baylor back in '94 and they completely removed the Baylor name. And so now it's just Texas A&M College of Dentistry. After my 4 years at Baylor, then went and did an AEGD, which stands for an Advanced Education in General Dentistry in New Mexico. So for those of you who have visited New Mexico, this is downtown Santa Fe area, and that's their balloon festival. If you haven't had a chance to go and visit, they hold it over 2 weekends in October. It's magical. So I was very blessed to have that opportunity. During my AEGD, we were on call. We are the only, I want to say, dental specialists in the area. Most of the dentists are just general dentists. So whenever something really crazy would happen, patients usually would come to us, to our clinic. We were attached to the hospital. And so this was a kid who crashed from a skateboarding accident on his way to college. And so he came in and I tried to patch him up as best as I could, even though he was really bloody and nervous and anxious. But that was a really fun case. This was another one. I'm sorry if this is too gory for some people. This was a guy, it was Christmas Eve. He got hit in the head with a beer bottle. Ooh. And so kind of big laceration to the lip. His front tooth got pushed out and I had to come in and I numbed him up and put his teeth back together, splinted him up like what you would see with braces, and then he was okay. Also during my time in New Mexico, I did a lot of surgery. I was grateful for that experience as well. If you guys can see, here's an implant we placed here and another one we placed here, and we even did a sinus bump. So I had that experience as well. So I have a very strong surgical background. A lot of specialists in my arena, prosthodontists, they don't have a surgical background, but I'm able to take my surgical skills and marry them with restorative. And I will show you guys how that's an advantage. So after, my time in New Mexico, I'm gonna put this. So after my time in New Mexico, I was, I felt like I got a lot of surgery, but not a lot of restorative. So I told myself, well, I want to learn more restorative. So applied to A&M again and got into their PROS program. It's a 3-year PROS program. It's actually pretty intensive. I got to do more surgery, did a lot more full mouth cases, full mouth rehabilitation cases. We saw patients who were older, patients with a lot of problems, patients with severe, medical underlying conditions that not the general dentist can handle. So that was great. Part of our program, it's one of the few in the country, is we do, in addition to our clinicals, we also have to do a lot of research as well. We are the prosthodontists, we are kind of, the I guess if you want to say the know-it-alls when it comes to materials, digital technology, what's new out there. We have to stay on top of all of that. And so, in corporate dentistry, they try to sell dentists all of these different things, and they say, hey, this is great, this is so much more better than what you're using, try it, it's awesome. But what we do is we say, whoa, we'll try it, but first we gotta test it and make sure that what you're saying your product does indeed do that fact. So you can see I'm very pregnant here. This is when I was pregnant with my third. Last year, defended, basically we were looking at reline material. So if those of you with dentures in your mouths, the reline material basically is, when you have a denture and it becomes really loose, you bring that, it's something that you can put inside of your denture that your dentist can do for you and allows the denture to have a more secure fit. So what I was looking at was, does traditional denture reline material bond well to printed dentures? So now we can print dentures, we can 3D print them. There's a lot of things that we can 3D print, and dentures is one of those things. Now we can 3D print teeth, and I'll show you later how we can 3D print frames for different kinds of prostheses. So that was the underlying base for my research. Just to kind of show you guys the machine. It was a lot of fun. And that sound, I'll never forget that sound, but basically it clicks. That's, me taking a sample of a 3D printed denture and relining it and then testing it out. So anyways, we had baby girl a month later. So that's part of that. And so here she is, went on maternity leave during the height of COVID. So April of last year. And then we went back to work. Kids were distance learning. My husband, he works from home, and there's baby. So there's kind of a screenshot of our clinic in one of our operatories. So if you see this red thing, right corner, that's our printer. So I still do a lot of printing, and we try to be COVID friendly and COVID sensitive. So we do have a medical grade HEPA purifier. It basically circulates the air every 15 minutes. It brings in clean air. What we do generates a lot of aerosols, and I just want to make sure that when I do see my patients, I'm as cautious as possible. So when you come in, the first thing we do, I tell my office manager, and you guys will see a picture of her in a second, but the first thing we do after the consult, after I kind of get an idea what it is my patient wants us to do, is we do something called the diagnostic workup. I say, okay, next time you come in, we're going to do a diagnostic workup. And they're like, well, what does that mean? But basically that's just me gathering a really detailed medical history. I want to know every single medication you're on. There's so many medications that people are taking these days, antidepressants, antihypertensives, stuff for your diabetes. The list goes on and on and on. And all of that affects saliva flow. It affects the way you're going to heal if we do end up doing dentures. Maybe your medical history is so complex, I can't do implants. So it's something that I got to look at. And then obviously I want to know what it, it's so easy when we go into these really difficult cases, it's so easy to get lost in the forest. If I see tree, and I'm like, hold on, let's regroup. I want to make sure that I go back to that I'm helping the patient out, that I'm really taking care of what their chief concern is, because it's interesting how many patients I see, it's like 2 years later, and they're like, yeah, we did all this stuff, but, doc really didn't take care of what I really wanted. So I want to make note of that in your chart so that we always go back to that. This was the patient's chief concern. Their concern was their front teeth. Their concern wasn't really their back teeth. So, and obviously, an exam, we look inside the mouth, we take bite records, because I go back and I look at your casts and I study them, and we do something called an occlusal analysis. And obviously full mouth x-rays with a 3D scan. Also in my practice, we do intra and extra oral photos. So we take photos inside the patient mouth, also outside. I want to see patient profile. I want to see your face. We have kind of these asymmetries in the face, sunken in face. If you haven't had your teeth for a long time, I want to know where we started, so I know how to customize a treatment plan to you. It has to be customized to you. What I do to patient A is not the same as I do to patient B. And you guys will see pictures of that too. We also do digital impressions when I can, when possible. And I also do something called a diagnostic wax up. And I'll show you that too. So here's kind of one, a patient model. We did her scan, and I input that into my software and build up basically a digital model. That digital file then gets sent to that red box that you guys saw, my 3D printer. It gets printed out, and then that's what we're left with. And then I come back in, and these things are so accurate, down to like 50 microns. It's amazing. And I go back in and kind of add my final touch and wax up things the way I want it to look like, the way I think where I'd want the teeth to be. And then the next step would be, okay, well, let's try these teeth in the patient's mouth and see how it fits them, how it fits their face, if it looks good. Does it look good in relationship to the gums? Where are the gums? Where's the lips? Where is, So again, before we start on your back teeth and your bite, we first have to ask the question, where do 8 and 9 go? Those are your two centrals, basically. That's the golden question for any full mouth case. And before I can answer that question, I take all this information that we gathered. Sometimes it takes me 2 appointments to gather all of that information, because I have a patient who can't sit in my chair for more than an hour because they have severe back pain. And they're just like, doc, I'm really uncomfortable. And I say, no problem. We can divide it into 2 appointments. It's not a big deal. It goes back to, this is the reason why I made my practice the way it is, because I truly believe in individualized, customized care. So, we look at face height, lip length, mobility of the lip. Some patients, and I'm sure you guys know that one person, they smile and you see nothing but gums. So I have to know, some people, they smile and you barely see their teeth. So all of these factors have to come into play, right? The extent of their smile, the length of their maxillary teeth, of their top teeth. So tooth color, tooth alignment. I'm looking at all these things, and I'm making note of it. And this is kind of what we do with every patient. So, we also looking, and then you ask, well, why do you need my pictures, my before pictures? It's not for those sexy Instagram before and after photos. I could care less about that, right? It's more for diagnosis. It's more for the teeth have to match, believe it or not, the eyes. They call it the interpupillary line. But then you say, and I had a patient where his eyes were a little crooked, and I grabbed my attending and I'm like, Doc, my patient has crooked eyes. What do I follow? And he said, well, you go parallel with the floor. But, I want to make note of those things before we start constructing the smile. I need to know these anomalies before we move forward. So, and again, we take these pictures. I want to see how much incisal show, how much tooth are you showing, right? Also, do I have to do any, what they call crown lengthening? If you have really short teeth, do I have to build the teeth up? We ask ourselves, are we going to go north or south with the teeth? Sometimes I got to go north. Like I said, those patients, when they smile and they have that really gummy smile, that's usually what I have to do. And again, tooth color is very, it's multifactorial. Patients, they say, the worst thing you can do is show a shade guide to a patient, say, what color do you want? This is fallacy. This is something you don't do, because there's intensity of the color, there's depth of the color, there's something called translucency. How translucent are the patient's teeth? And then we follow that and we make sure that everything looks, because the last thing you want is teeth that aren't matching up with one another. All right, so just a couple of cases. This is my son, actually. Aww. My husband, he sent me a picture and he was like, Amira, what do I do? And yeah, of course I was freaking out, right? And so came home and, calmed him down a little bit. Thank God it wasn't in the nerve and the nerve wasn't involved. Otherwise it would have been a root canal. But I did what any other prosthodontist would do. I took my mom hat off and put my dentist hat on and said, okay, we're going to get an impression. So this is before my 3D printer, and printed that out and printed out, waxed up and you can see kind of the wax right here, trying to make them look symmetrical, because, he's going to continue growing and the space is going to fill up. So I have to make note of that. And made a jig. I make these little jigs so that it helps me kind of guide me back to how I want everything to go back to my diagnostic wax up, right? And then here's his smile. So sweet little guy. But anyways, that's how that kind of fixed up. So I see a lot of trauma cases. We also do a lot of removable. It's so funny. A lot of dentists don't enjoy doing dentures. And there's something, my dad, okay, he'll cook a meal and then I'm like, oh my God, this is so good. What's your secret? And he's like, do you really want to know my secret? And I'm like, yeah, what's your secret? And he goes, I cook from my heart. And so dentistry is 100% the same way. When you do something because you want to do it, because you enjoy doing it, it shows. When you do something because you're just doing it for the heck of doing it, it shows. So, it's funny. They used to call me the removable queen in dental school. I used to set up teeth just because I enjoyed it. My friends would be like, here, set my teeth. I hate setting up teeth. And I still set up my own teeth today. I do the majority of my own lab work. So everything is done in-house. And this is a case I did, actually. So this gentleman came to me and he just got over his tongue cancer. And I'll show you guys pictures of that. And he had these hideous dentures that he couldn't wear, that were so painful. He had ulcers all over his gums. And I said, whoa, let's step back for a second. Redid, like I said, I do these intraoral photos. Do you see the blood, you guys? And the red ulcers? Yep, that's from his dentures. He had really dry mouth because of his cancer treatment. When they did radiation to his jaw, it basically killed his salivary glands.
Mm.
So imagine wearing dentures with really dry mouth. It's very hard to do. It's not fun. And there's a picture of the bottom. So you can even tell in these pictures how dry his mouth is. And then he had a failing implant that never integrated. So that's why I said implants are not for everybody. You know, he had these implants placed after his radiation to the jaw, which is not really recommended unless you go undergo some sort of hyperbaric oxygen therapy. But anyways, and there's a picture of his tongue. You can kind of see where the scar tissue, where they cut away the cancer. And just FYI, every patient of mine, before I even look at the teeth, I look at the tongue. Everybody gets an oral cancer screening, and I don't charge additional. I think that's silly when dentists say, "Oh, we charge another $50 for an oral cancer screen."
You're already in there.
Pretty much, yeah. But this is what we came out with. You know, I went and I got him these beautiful Ivoclar teeth. We set them, and he came in a couple of times and I said, "Do you like the way the teeth are set up? They're in wax. I can move it." You know, I made sure everything looked good. Do you see how he has a very thin upper lip?
Mm-hmm.
And so we have to accommodate his teeth to his smile, to his anatomy. So, gosh, look how much younger he looks. He even called me and said, "Hey doc, can I get another pair of dentures?" And I said, "Oh my gosh, you're just gonna," I made them from scratch, and I apologize, you'll have to pay for another set. But if these were digital, I could have just printed them for him, because he was afraid. He has a pet at home.
Aww.
And his dog, yeah, dogs love dentures, by the way. You need to keep your dentures away from your dog, from your pets.
And if
So,
you haven't seen the pictures online, you need to look them up. They're hilarious.
yeah, I can't tell you how many dentures I've repaired because dogs have played with them. But anyways, so there's that. Here's another case. He was my overdenture case. And I know I'm going to get a lot of questions about overdentures. What is that? And what does that mean? But so here's kind of where we started. Yeah, really bad hygiene, really bad gum disease, just really poor state of oral health. His teeth were really mobile. But anyways, what overdentures, we have to make note, you know, basically what this is showing is you need to make sure sometimes these dentures, these implants are not placed in the right position. And then what ends up happening, because there wasn't enough room for these overdentures, for the dentures, they end up breaking easily. So I see so many times patients, they first go to the oral surgeon, they say, "I want implants and I want a denture to snap into these implants," which is wrong. You know, really the way it's supposed to be handled is you're supposed to go to your restorative dentist. They need to figure out the space and the thickness and what needs to happen, because sometimes we have to kind of trim away some bone to make room for the restorative. And then the implants are placed. So, you know, I'm just showing my 3D printed guides. I made surgical guides for my surgeon. The implants were placed, they healed later on. And then, so that's top and bottom. We placed 8 implants for him. I also, because he did tell me he's got 2 dogs. And also, anytime I place more than 2 implants for an overdenture, and overdentures, they snap into these implants, right? You know, I make sure that I reinforce it with we call these chrome cobalt. So it's a metal bar. And they're just really strong and they're really hard to break. So there's that metal reinforcement in the denture, and then it's kind of got this U shape. So he did say he had a hyperactive gag reflex, so I made sure to relieve the palate. So, and that's kind of the little buttons that goes into your denture, and that gets snapped into the implants. And so he told me, he said, "I want a really white smile. I want a Hollywood smile. I want to show as much tooth as possible," you know. And we went through several rounds where we were trying in the teeth, and, you know, I would have changed the smile up a little bit, but beauty is in the eye of the beholder. And ultimately, you know, it's my patient that I want happy with their teeth. So that's kind of what he settled on. So the same thing with single implants. Even you think, oh, well, it's just a single implant, I'm just going to get it done really fast. But we have to, again, Is this a tooth that's going to go in the anterior in the front, or is it a tooth that's going to go in the posterior? So we have to be very mindful of that as well. Usually with our anterior implants, we need a little bit more space, so 14-14 versus our posterior. So here's a case that I did. My patient, she came in. If you can see from the x-ray, that black on both sides of her underneath the crown, there was a lot of decay. And then there was a lot of bone loss too, down to the furcation is what we call where the roots kind of split. We extracted that tooth, and it's funny, we call these extractions atraumatic extractions. I mean, an extraction is always traumatic to the patient. But what that means is that the tooth is extracted in such a way to maintain as much bone as possible. The worst thing, especially for a site that eventually is going to be a place where an implant is going to be, you want to maintain as much bone as possible. So in this case, I extracted her tooth atraumatically, right? And placed the implant where the bone was in between the roots. So we call that the interseptal bone, and placed it immediately and harvested and filled the roots with bone, right? So kind of we call this the mesial and then the distal root. So that got filled in with bone grafted, and then she healed beautifully. We came back and put a crown, and that was a crown I made, old fashioned, you guys, like casted it with the fire and good times. Stacked my own porcelain. It was really hard. It took me 2 weeks to do, but it was, they did that to us on purpose. They want us to do all of our own lab work so that we could be appreciative of the components of what needs to be present in order to ensure long-term longevity and success of the final restorative. And so you guys are probably wondering, well, why is there a hole in her crown? Because my crowns, for the most part, they are usually screw retained. I don't do cement retained crowns because they have a tendency to pop off. So if you guys ever had a crown that popped off. Also, what we found with our cement retained crowns, if the cement is not cleaned correctly, it can go back in and reinfect the implant. So there's that as well. So whenever possible, I try to make a screw retained crown. Also for this patient's crown, I did a custom chairside stain. And so we tried to match it as best as possible to her adjacent two teeth. So you really, and beautiful emergence with the papilla, with the gums. She's healing so nice. There's no inflammation. It was a great case. It was textbook. Another case, but this is called, I wanted to show this case, it's called a guided bone regeneration. This is Beatrice. She came to me, she had a lot of bone loss, a lot of, her roots were exposed, and there was actually decay on the front side where the cheek meets the tooth. So the other thing too that made this case difficult is she had what they call, you want to say crooked teeth, but malocclusion, where the teeth kind of were tipping in this way. So it didn't allow for a lot of restorative space. So we did it so that, I'm sorry, let me go back for a second. Go back. We did it in such a way that, we built up the bone. There was a huge defect. And if you see this kind of little, looks like a spider web mesh. This is a titanium mesh that helps hold the bone in place. She wore this for about 6 months, and then I came back in and removed the bone, removed the little screws and the pins. Once we did that, we came back and placed the implant. And then after the implant healed, we came back and placed the final restorative. And then you could see she didn't have room for one molar. She had room, it was like 2 premolars. And this was the best way for us to construct this so that it was, so that we call this restoration so that it's conveniently hygienic for the patient. The last thing you want to do is place an implant for a patient and then place a prosthesis that doesn't allow the patient to clean underneath the prosthesis. Because just because you have an implant doesn't mean it can't fail. Bacteria loves titanium because titanium has a very rough surface. Plaque adheres to titanium, so you have to go in, you have to clean it, and that's the only way to keep it healthy. So, but if the patient has a restoration that doesn't allow them to clean and to be conveniently hygienic, that's usually what leads to failure. And so that's how it looked in her mouth. So here it is. The access is right here in the back premolar. And then we call it a cantilever. So it's kind of like a small bridge. But she loved it. And it worked really well for her. So now I wanted to touch base on hybrids. Hybrids, they come in many flavors. So if you guys have heard of teeth in a day, all on 4, that's kind of what a hybrid means. So the term hybrid came from, it's a fixed, so it doesn't come out, fixed, complete denture. That's what a hybrid is. And, you have to be very mindful. You have to be careful that you're planning these out correctly, because again, we need the restorative space. You have to be careful when the patient smiles that their lip doesn't hit where the restoration and the gums meet. That would be considered failure, right? Even though the implants are fine and everything's fine and everything's held up well, it doesn't mean it's success. So here's a case. This patient, he was so sweet. He was born with a cleft palate, 54-year-old male. And we actually did some, jaw surgery in the top to help try to close that defect. And we also, my surgeon, grafted bone from his hip and put that in the defect where he had his cleft. And that was our 3D print, and I guess what you want to call the diagnostic wax up. And this is kind of what we do. And that was his guide that I made for him in the surgery. That's when the guide is fixed. So my surgeon follows where my guide is. Those are his implants in the bottom. And that's his smile. He had no teeth, and then he walked out like that. Wow. It was awesome. Yeah, it was a great case. It was a good day. So here's another patient of mine. He came in, poor guy. He was at the fair and he was eating a funnel cake and he broke his front tooth. And that's how he presented. You can kind of see he's got a little titanium post there, patient mouth. And then we do the surgery. This step is just showing how I take, an abutment is just a fancy word for a post for the implant. I take these in the lab and I anodize them. Change color from silver to yellow. And take an impression, customize stain. Oh, sorry, that's stained it, did a customized staining right there. And then it went in the patient mouth. And then he went home and healed. So again, I told you guys, I work with patients who have, these really complex medical histories, right? This is I call her my golden patient. She has golden heart syndrome. And so she was born with a really short mandible with a really short lower jaw. The oral surgeons actually brought me to this case because she had a really severe infection on the bottom and she lost all of her bottom teeth. And so that's kind of what we were left with. So brought her in, did my wax up based on, her jaw. That was the best that we could do for her. And then she tried in the teeth and I made sure the teeth looked good. And so there she is with the teeth in her mouth. She was really happy with it. And she was like, all right, move forward, doc. I'm happy with my smile. This is where I want my teeth to go. I said, okay. And so we made a guide for her and that goes in the mouth. Sorry if it's too gory. And then, delivered teeth for her. This case is a little bit more complex. Believe it or not, he came to me, he has upper and lower dentures, but he's been wearing these dentures for, he told me at least 30 years, what I showed you guys before. And but the thing about the upper jaw, that I want to make note in this case is the bone in the upper jaw is really soft in comparison to the lower jaw. So when you lose your teeth in the upper jaw, man, it goes by really fast. So for him, we couldn't just place traditional implants. I had to do something called zygomatic implants, or this is called a quad zygoma. And basically these implants, I mean, I kid you not, these are like 50 millimeters long, and it goes from here to your cheekbone. And that's where we get anchorage, just because there's no bone in the upper jaw. Lower jaw, I was able to put regular, I mean, you see these are just regular implants. The vomer is actually a bone, it's in your nose. And so this went in his nose. But then look what we came out with. We were able to anchor something, and he was able to wear something fixed for the first time in more than 20 years. Really happy. It's really interesting, these cases, especially the gentlemen that I see, you know, when they don't have a really nice smile, they try to grow out their mustache to kind of cover that. And then when they come back to me for their post-op and I take their photos, their mustache is all turned away and they want to show off their new smile. So I thought that was really interesting. It was a lot of fun. So, you know, when I say try your teeth, you come in and you try the teeth out. We don't just jump straight to, a lot of people do. A lot of dentists do that. Who are not specialists, who are not prosthodontists, right? They just go and they just jump straight to the porcelain, or they jump straight to the acrylic. And that's wrong. You know, we have to take your bite out for a test drive. I want you, because there's more to your bite and there's more to function than just tap, 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 and then chew side to side. Your function is so much more complex than that. And I just can't mimic everything. I can't mimic your bite 100% in the dental chair. Then when you go out and you wear your bite for a month, and then you come back to me, you say, well, doc, I'm hitting here a little bit more than here. And then that's when I start to see those wear facets, and then we start to adjust the bite accordingly. That's really important. Or maybe I opened your bite up and then you're like, you know what, doc, my jaw is starting to hurt. It's a little bit tender, you know, and then we have to go back to the table and say, okay, well, how can we modify this bite so that it's more comfortable to your anatomy? So what I'm showing here is a bite, you know, we did his upper teeth in porcelain. This is in zirconia. And then his bottom teeth, you know, see they're set up in wax. And, you know, we tested out the bite, and then we can come back. And then you know, this is acrylic on the bottom. So it's two different materials, but you know, then he was really happy with that, and we were able to move forward with the case. So that was at delivery. Well, am I on time? Oh, good.
You're doing good. Oh my
All
goodness.
right. So I wanted to make mention, I know I wanted to talk about sleep apnea, but I felt like I was going to run over time. But please visit my website. I'm actually, I'm a part of the sleep study group with the residency. I'm still in touch with the school. It's under the direction of Dr. Emmett Schneiderman. He's running this sleep group. The thing with sleep apnea, you're basically choking while you're sleeping, you know, and it's really bad for your health if you don't get a good night's sleep. And I wrote a whole article about that on our website. So if you visit dentalhealthspecialist.net, and here's our information, you know, you can read more about sleep apnea. You can also follow us on social media. We're on Facebook and Instagram. This is my beautiful office manager, Aya Shoshani. So when you call the office, you'll either get a hold of her. If it's after hours, you get a hold of me. And I said that correctly. I do answer my phone after hours because, you know, my patients, things happen, I understand, and we try to be as accommodating as possible.
That's awesome. And I would love, if you're open to it, Dr. Awad, having you do a presentation on sleep apnea. So,
yeah, it's a lot.
I would love that. So I'm going to be sending you an email. First of all, fantastic job. I do
Thank
have some
you.
questions that came through.
Oh, okay, sure.
So let's, someone had asked your location, but I put the address in the chat for anyone else that was wondering where their office is located. It's at 7965 Custer Road in Plano.
Correct.
Okay, so someone asked, and this is a great question, how does printing compare to the porcelain crowns? Like pros, cons, tell me.
So it's the material, right? So printed resin, so the resin that we use in the printer, it's very similar to the material that they use for your fillings,
Okay.
for tooth color fillings. So it's not that strong. It can break under several pounds of pressure. So that's why typically for our final crowns, we do porcelain. We don't have it printed. The only time I do printed crowns or printed dentures, it's for my temporaries. It's not for a final. Now, I will say within the last month or so, I think it came out in December, they did come out with a new resin where they're saying it's been FDA cleared for a final crown. But I wouldn't put it in my patient's mouth. I've already done my research on the different resins when I was looking at the printed dentures, and it's not as strong.
Right.
It's inferior, and I don't feel comfortable putting an inferior material in my patient's mouth as a final restoration.
So it definitely would not be recommended for a long-term
No,
solution.
not for long term.
Yeah.
No, absolutely not.
Okay. So this is a good question. What are procedures for people with a small mouth structure and those who can't handle internal x-rays very well?
Say that question one more time.
So Nancy, do you want to take yourself off of mute and you can explain what you were asking?
Oh,
Okay.
internal.
Yeah, so I have a small mouth structure and I gag really easily. And when you try to put the x-rays, especially the cardboard ones in my mouth, I just spit them back out.
So right now, my office for the most part were digital. So I've actually invested in a new sensor that's smaller than the traditional, those little cardboard things. That's kind of how we've tried to alleviate that, because a big majority of my patients are gaggers, so I understand that. And we're really sensitive to that. And then also, it's either myself or Aya that's taking the x-rays, and we have really small hands. So
that helps.
I'm not sure if that helps when we're working inside the patient mouth too.
Fantastic. Okay. So I did have someone send me a message and ask, are you also an endodontist?
No, I am not an endodontist. Endodontists, they are root canal specialists. I do root canals. That was something that we got extensive training in New Mexico. However, for those really difficult, what they call retreatments, so teeth that have already been treated with a root canal, it's better to see the root canal specialist because they have that really special, huge microscope. And so they can really see inside the canals really well. It's interesting. We have 9 different specialties, the dental specialties. And so we're all trained so differently according to our specialty.
All right. Well, if anyone else has any questions, please feel free to put those into chat for us. Also, guys, feel free to take yourselves off of mute. Would love to hear a round of applause for Dr. Awad. I learned a lot. Oh my goodness. Well, and anything teeth, you guys have been on my journey, some of you, because I've had a lot of dental work done this year and a lot of teeth pulled in the past year. It was the great time, the best time to do it. So seeing any of it is always fascinating to me because I'm like, oh, they did that, or oh, they're going to do that to me. But Wow.
So I got another direct message. It said, are implant dentures way more expensive than regular dentures?
Great question.
So what makes it more expensive is it's not the denture itself, it's the components. So the implants, they run around, I want to say about 2,000 a piece, implants. And then we also have to buy the post that goes inside the implant, and that comes from the manufacturer directly. They're prefabricated. And then there's the component, if you guys remember that one overdenture where I showed y'all with the blue buttons. And so then I have to buy that. And then, it kind of, all these little pieces add up. And so roughly we're looking at, for an overdenture with the implants, with the components, they're around 12,000 an arch.
Okay.
For everything from start to finish. But that can go up or down depending on how many implants we're placing. Are we placing just 2 or are we placing 4 for more retention?
Okay. And as far as your dentistry services, so we had someone asking about they need tooth pulled, a spouse will need a bridge, but they don't have dental insurance. Do you work with cases like that?
Absolutely.
Perfect. Yeah, in that case, I would honestly recommend Judy and Gil that you reach out to them directly. But go ahead. I'm sorry, Dr. Awad.
Oh, no, that's fine. We try to do it so that we remain, when I sat down to go over, when we went over our fee schedule, I said, Dara, what's really important to me is that we remain affordable. But at the same time, what you are paying for is that individualized care, because we really are only seeing one patient at a time. I'm not bouncing back and forth between, oh yeah, hold on, let me go numb and opt 2. Oh yeah, okay.
It makes such a difference. Oh my goodness. Yes.
Thank you. No, we don't do that. We don't do I call that ADD dentistry. I don't do ADD dentistry.
Yeah. Let me tell you from my experience many, many years ago, I'm not kidding. I sat in a dentist chair for close to 6 hours because they were doing that and going back and forth between me and someone else. It was insane. That's wonderful. Okay. Do you do 1-day crowns in your office?
I don't do 1-day crowns because that utilizes the CEREC machine. I don't like the CEREC material. It's not as strong as zirconia. The porcelain that I use is zirconia, so it's interesting when you cut into the CEREC crown, it's like I'm cutting into butter. So again, I'm not going to put something in my patient's mouth that I feel inferior. Now, I could get a mill that mills zirconia in my office, but that machine is like $150,000. And the upkeep is ridiculous. So typically what I do is I send the file out, the digital file, to the milling center, and then they mill my crowns for me, and then we get them back.
About how long does it take for those crowns to come back?
When it's a single crown, they usually take about 2 to 3 weeks. But now when we're talking about a full mouth case where we have to make sure all the contacts are correct and the bite is correct, I'd rather do everything in the lab before my patient comes so as to minimize my patient sitting in the chair.
Perfect. Yeah, I've noticed that it doesn't take as long to get crowns back anymore. And do you do just regular dentures is one of the questions.
Absolutely. It's such a lost art. Yeah. It is really a lost art. I love doing dentures. So.
This is a great question. Okay, this is actually a question I'm really interested in as I age is the person sent me a message and said that they have TMJ. Can they still get dentures with TMJ?
So actually, sometimes that TMJ pain is secondary to a bite that's been overclosed. So once we open your bite back up and we increase what they call the vertical dimension, it puts everything back to where it was normally. And so what we see is we get an alleviation of the pain.
Very interesting. Hey, I sneeze and it hurts sometimes in my jaw. So like, it's crazy. All right. Well, I have a lot of well done, great presentations, great
Thank you, guys.
information. I mean, gosh, thank you so much. So guys, you know, feel free if you need any help whatsoever, dentures, implants, just call Dr. Awad and she's there to help. You can definitely tell she's passionate about what she does, which really, I mean, I get the do what you love and it shows because
Oh,
it's what I
thank
do
you.
too. So
appreciate
thank
it.
you. Thank you for joining us. Round of applause once again. Thank you so much for all that you did today. I'm not kidding. I'm reaching out. I want to do a sleep apnea presentation. So
All right. Will do.
it's a good topic for everyone. So thanks, guys. Have a great day. Don't forget to join us tomorrow, same time, same place, and on Thursday for bingo. Bye, guys.
Bye,
Bye, guys.
Thank you.
Thank you.